have the privilege of chairing this plenary session. We pick the plenaries for good reason every year, and there are new things to talk about in cardiotoxicity, particularly things like new guidelines, but also in line with, I think, most other cancer conferences around the world. We are challenged as we are starting to use the new immunotherapies with different side effects in a number of organs, and that includes the heart. So it's very relevant, and we have a stellar cast of speakers. Now, we probably won't have time for questions, but the speakers would be available after the session if someone has something. If we do, we'll allow a couple, but I'll go through the talks. And our first talk, I'd like to introduce Professor Thomas Suter, who's a Professor of Medicine and Cardiology at the University Hospital in Bern in Switzerland. He's had a particular long-standing interest and is indeed the European expert on cardiovascular side effects of cancer therapy. He trained in both Zurich and in Boston, and he's here to talk about ischemic heart disease in the cancer patients. So welcome and thank you.
Dr. Albert, ladies and gentlemen, thank you very much for the invitation. Great to be here, and also great that you guys listen to a cardiologist. And this is actually my only disclosure I have. I'm employed by a university hospital that serves about 1.5 million people, and we see about 700 to 800 patients with cancer and cardiovascular problems. So I was assigned the topic myocardial ischemia in oncology patients, and if you think about that, I think it's important to differentiate between disease-related and treatment-related issues regarding myocardial ischemia. Let's quickly focus on disease-related issues. Now, what we frequently see, that is 3 to 5 times per year, are the leukemia patients who have acute myeloid leukemia and have cardiovascular side effects, and in particular ischemic side effects. And there are several reasons why this happens. They have leukostasis, they have thrombotic disease because of their leukemia. And this is in particular a problem for us because these patients have a substantially decreased prognosis. If you compare patients with AML without myocardial infarction, you see that the survival rate of patients with myocardial infarction during the acute phase of their disease have a substantial decreased prognosis. Now, there are other cancers that are associated with myocardial ischemia, in particular myocardial infarction, but they're not that frequent, and I won't cover this. Now, what do we do when we see patients who have leukemia and have a myocardial infarction? We typically treat there, and the modern treatment now includes percutaneous coronary intervention. We usually place a stent in these patients, and that indeed causes the next problem. In that we treat these patients against thrombosis in the coronary arteries with aspirin and all the other platelet inhibitors we now have. And you can imagine if you have a patient with AML and a patient who needs treatment for AML, and then you treat this patient for their platelets, that is causing a problem. We usually do these treatments up to 50,000 platelets, continue with aspirin until 20,000 platelets, and if the platelets drop below that during chemo, for example, then we would stop aspirin in these patients. But this is a particular challenge for us on a daily basis, I have to say. Now, another issue, and I'm sure this is going to be covered by Professor Swain later again, is if these patients have myocardial ischemia, they have a substantially higher risk for cardiovascular side effects of the cancer treatment, in particular talking about anthracyclines here. And many of these patients obviously are treated at least initially with daunorubicin, and we see quite a few of these leukemia patients who in a later phase of their disease have substantial systolic dysfunction and heart failure. Now let's focus on treatment-related myocardial ischemia, and I think this is a little bit more relevant for you. So it is important to understand that there are different pathophysiological mechanisms which eventually lead to myocardial ischemia. We have the conventional pathophysiology, that you have arteriosclerosis in a vessel, and this is leading to plaque rupture. Plaque rupture then leads to the formation of a thrombus. This is what the typical pathophysiological mechanism is of a myocardial infarction. However, with some of the cancer treatments, we have another entity that is the vasospasm, and I'm coming back to this. And other cancer drugs lead to thrombosis in the arterial bed, particularly also in the heart. Now, it is important to differentiate the mechanism because the treatment and prevention is completely different. And the European Society of Cardiology has actually published their own guidelines. This is a consensus document. We published this in 2016. And whatever I'm going to tell you now is actually based on this document which I co-authored as a senior author. Now, another issue I think when you think about cancer and myocardial ischemia is that you think about the phase the patient is. We usually differentiate in 3 phases: the phase prior to the cancer treatment, the phase during cancer treatment, and the phase after cancer treatment. And for the purpose of this part now, let's just quickly focus on the phase during cancer treatment. Coming back to the cancer drugs that potentially can induce myocardial ischemia or myocardial infarction, here you have a summary of the endothelial toxic cancer therapies. The anxiolytic agents, and particularly cisplatin, is one of these drugs. We see this more or less once per year in our hospital setting. The incidence, when you read the literature, is roughly about 2%. It seems to me high, but it's clearly it is associated with cisplatin. Is there a prevention? We have absolutely no idea. We don't know. We usually don't do anything in terms of prevention. One could argue, well, patients who are at risk should be on aspirin, but there is no clinical evidence to support that. Having said that, though, I think it is clearly important that you identify the patients at risk before you do the treatment. And patients at risk are typically patients who have cardiovascular side effects. These are typically the patients, the smokers, the hypertension patients, patients with hyperlipidemia, you name it. Now, another drug class that may cause endothelial toxicity are the VEGF inhibitors, although I think they are in another area more important. I come back to that. 5-FU also has been described as endothelial toxic, but my feeling is they are far more important in this context. That is the induction of vasoconstriction. So what these drugs do, and in particular 5-FU, capecitabine 2, is they cause vasoconstriction on the arterial bed. And typically what you will see in these patients is that these patients experience angina pectoris. It's rare that these patients experience heart attack, but angina pectoris. And the mechanism is multifactorial, but what we usually do in these patients, we treat them with anti-vasospastic drugs. So calcium channel blockers, for example, we typically would use amlodipine and nitrates, and frequently we get by and we can treat the situation, and the patients can continue to get their cancer treatment. Now, I should also say, if you use 5-FU and you have patients who have vasospasms, it is frequently better to use bolus treatment if possible rather than continuous infusion. The incidence is a little bit lower of this coronary vasospasm. The rate of this occurrence is quite controversial. We see this about 10 to 20 times per year in our center, but if you read the literature, the incidence is up to 10%, which it seems to be a little bit high to me. So how about thrombosis? And this is something I'm really concerned about. This is the typical VEGF complication, that you have thrombosis not on the venous, we know that, on the venous side. For example, bevacizumab causes up to 10% thrombosis on the venous bed, but it also causes thrombosis on the arterial side. And we see this about also 2 to 3 to 4 times per year, typically patients with metastatic cancer, in stomach cancer, for example, kidney cancer, that have a myocardial infarction, most likely due to the VEGF inhibitors. And that's particularly a problem because you can't stop the cancer treatment in these patients. So what we usually do is we try to lower the dose of the VEGF inhibitor, give all the medications we can give to vasodilate the coronary arteries, again, amlodipine and nitrates, and frequently we get by, treat these patients also with aspirin. Now it is important to understand that this VEGF receptor is important in the cardiovascular physiology too, and it has both in the cardiac myocyte as well as in the endothelial cell important factors. And you see here, one factor is that endothelial cell survival depend on this VEGF inhibitor, and this is one of the pathophysiological mechanisms why we see this. Let's move on to after cancer treatment, and this is very close to my heart because I see many of these patients. What do I talk about? Well, some of the cancer treatments you are using, and I'm talking here about alkylating agents, platinol-based agents, cause premature arteriosclerosis. And here, for example, I show you the data from Holland. These are patients with testicular cancer. And we know quite well that these patients, particularly if they are treated with bleomycin-containing regimen, have premature arteriosclerosis, not only in the coronary arteries, but in the other vascular beds, such as carotid arteries. And I think it is critically important that these patients, they have a high likelihood to survive the testicular cancer, but these patients need to be followed. We look at these patients every 5 years, see if we have any evidence of ischemia, both in the heart and in the rest of the vascular bed. Of particular concern are the patients who have undergone radiation therapy, and particularly mediastinal radiation therapy. This is a well-known cardiovascular side effect, and this is actually a paper that just has been published from Sarah Darby's group. This is now breast cancer treatment. And you look in the evolution of radiation therapy, this for breast cancer, this anterior radiations, so to speak, from anterior to posterior, and then tangential treatment. Even with the modern type of radiation for breast cancer, the heart is truly, in particular when you treat on the left side, is truly in the field of radiation. You only have to expose the coronary artery with 3 gray of radiation to substantially increase the risk of late toxicity. And this has been shown by Sarah Darby in this nice publication in the New England Journal. So the hazard ratio for mortality, I'm talking about mortality for cardiovascular disease with coronary artery disease, is 1.6 in patients who have been radiated for breast cancer, that is. Now, one of the important factors here again is that if you have conventional cardiovascular risk factors, the risk is substantially higher. And we feel it is critically important also to see these patients, to follow these patients, and to risk manage these patients, and particularly modify their cardiovascular risk factor. Now, this is mortality here on the left side. If you look at the incidence of coronary events, this is even higher, as this is expected. Now, another group that is of particular concern to me are the lymphoma patients. And this is Hodgkin data from Holland, from Amsterdam actually. And you see here in yellow, this is cardiovascular side effects over years. This is 5 to 45 years. You see here in yellow, if these patients with Hodgkin disease have mediastinal radiation therapy and anthracyclines, the incidence of cardiovascular side effects is exorbitant. Indeed, when you look at the 40-year follow-up, about 50% of these patients have cardiovascular side effects. And I think this just tells us that we are obligated to follow these patients. We can't let them alone. If the cancer is treated, if they survive 10 years, that's good, but keep the heart in your mind, please. This is really critical. And the particularly disturbing issue in this context is the younger the patient at time of treatment, the higher is the risk. And as you know, there are 2 peaks of Hodgkin occurrences, the one in the 20s. So if you have a patient in their 20s, they get radiated, typically mediastinal radiation. They have a substantially increased risk that they eventually will experience cardiovascular side effects. And here again, patients with pre-existing heart disease, they have a higher risk, and patients with cardiovascular risk factors, they have a higher risk. Therefore, again, I think we are obligated to not only follow up with these patients, but clearly manage tightly the cardiovascular risk factors. And this is how these patients look like. These are actually the biggest bulk of our survivorship clinics we see in cardiology. This is one of our patients. He's a 50-year-old male. He died in the meantime because of the cardiovascular side effects. But look at his history. In the 80s, Hodgkin disease, then non-Hodgkin disease, 2040, typical history, only radiation therapy for his Hodgkin disease in the 80s. But look what he had to undergo. He had an aortic valve replacement. You see this up here. There's actually quite some metal in his chest here. He had CABG, so coronary artery bypass. He had a pacemaker placed, 2002. Then he had endocarditis. Then he had several coronary intervention, because obviously this is progressive disease. This comes back, you have to treat this again. He had mitral valve stenosis due to radiation. We tried to open this up, didn't really work. He had class 4 heart failure. Eventually what we did, we percutaneously replaced, after his aortic valve already was replaced, we percutaneously replaced his mitral valve. So this is a very typical story for a patient who has been radiated to the chest for Hodgkin disease. So in summary, I think it's critically important that in cancer patients you identify the patients at risk. That's obviously something you want to do prior to cancer treatment. During treatment, keep in mind that there are some disease-related issues in terms of myocardial ischemia. They are the typical and known cancer therapeutics such as 5-FU, which cause vasospasm, and platinum compounds with long-term complications, in particular testicular cancer patients, long-term survival. But what is really close to my heart, because I see them on a daily basis, are the survivors of lymphoma. And I think we really ought to do a better job here in Europe, and I think for you guys in the US too, to follow up with these patients long-term. And long-term means 20, 30, 40 years. Thank you so much. And I want to thank my team here in Bern. Thanks you.